Each part of a person's gastrointestinal system has some specific function, and these are altered by surgery. The esophagus is a pump that actively pumps food from the mouth into the stomach through a valve, and the stomach is a giant reservoir for food. It also produces stomach acid that helps break tough food particles. And once the food particles are churned down to the consistency of toothpaste, the bottom part of the stomach serves as a pump to push this through another valve called the pylorus into the beginning of the intestine, which is called the duodenum. It is here that this food stream mixes with two important juices. One is bile from the liver, which is important in the absorption of fat-soluble vitamins such as vitamin A, D, E, and K, as well as pancreatic juice from the pancreas, which helps in the digestion and absorption of proteins and carbohydrates. The food and the digestive juices mix with each other and pass through the small intestine, which averages about 20 feet in length. In some patients, it could be as short as 16 feet, in others, it could be as long as 30 feet. The small intestine is extremely efficient in absorbing nutrients. So by the time the food really reaches the large intestine, there is very little left of it to be absorbed. Different segments of the intestine absorb different things more efficiently. For example, iron and calcium is better absorbed in the top part of the intestine, and vitamin B12 is absorbed more efficiently in the bottom part of the intestine. Out of the 20 feet, most people need only about 3.5 feet to absorb most of what their body needs. With a shorter segment of intestine, you would have to take more of certain types of nutrients in quantity so that the body sees sufficient amounts. Although patients are used to seeing the previous picture, the way the intestinal system is actually packaged in a normal human being is a little bit different. For example, the esophagus or food pipe follows the spine and is located in the back of the body. It passes through a hole in a big dome-shaped muscle called the diaphragm that separates the chest from the abdominal cavity and then joins up with the stomach. The stomach, interestingly, is not a top-down structure like it is shown in the previous slide. It happens to be a horizontal structure with the top part of it way in the back and the bottom part of it in the front. The liver is a fairly large organ that completely covers the stomach. So in order to get to the very top part of the stomach, which is where all the weight loss surgeries are typically performed, one needs to go past the liver to get to it. Hence the need to shrink the liver before surgery by preoperative weight loss. Some patients have a condition called hiatal hernia, which simply represents a condition where the union between the esophagus and stomach happens to be above the diaphragm as opposed to below the diaphragm, which means a small amount of stomach escapes through the diaphragm into the chest. This is a very common condition and doesn't necessarily preclude weight loss surgery unless it's very large in size. And that is why we assess patients by performing an endoscopy as well as a barium swallow study. Preoperative weight loss is important not only to shrink the liver, but also to decrease the pressure within the abdomen, which may be many times normal in a person who is obese. It also improves lung function and helps create working space within the abdomen to perform these surgeries laparoscopically. The adjustable gastric band is an inflatable napkin ring-like device that's implanted into the very top part of the stomach. The degree of inflation can be controlled by instilling fluid through a port that's implanted underneath the skin onto the muscle, typically in the left upper abdomen. As fluid is placed into this band, it pinches off the top part of your stomach, allowing only small quantities of food to escape into the bottom stomach. This is what brings about satiety and weight loss.